right, and we are back, continuing on the event. We're now going to talk about appendicitis, but I mean, we all know everything about appendicitis. Why are we having a session on appendicitis, right? It's as common as it comes. Still probably the most debated topic, and still every year new data is coming out to finally direct us, because I'll be honest, as something we've been dealing with forever, our outcomes still are not great with perforated appendicitis, so maybe we'll get better. So with that, we have a lot of new evidence being presented. We have Meera Kotagal, we have Tolu Oyetunji, we have Shawn St, and we have Whit Holcomb. Tolu is gonna be virtual, and these three will be here to teach us about appendicitis. Meera?
Touched on actually a couple of these articles already. Tolu, I think, is going to be on screen and advancing the slides, hopefully. So some of them are not new necessarily, but we'll start with a poll question, which I don't have control of the slides.
Oh, I can do the clicker.
Do you want me to have control of the slides? I
Here
thought
it is.
Tolu was going to have control of the slides.
No, you'll have it.
All right. Okay, so these are the topics that we're going to be focused on today. We're going to talk a little bit about non-perforated appendicitis, and then
Go up to the little plus sign.
all right, then perforated appendicitis, and then talk a tiny bit about non-operative management. Okay, so this is our first poll question. If you're looking at this picture, how would you classify the appendix shown in the picture? Perforated, gangrenous, suppurative, or it depends?
All right, let's hear thoughts from the audience. Come on, no quiet anymore. Miguel says gangrenous. Mindy?
I can't see the other side. Maybe the hole there.
She says, oh wait, you want to know if there's a hole? Cheater. All right. Anyone else? Justin, what do you think it is? Yeah.
So I think Shawn would agree with me that we would have two choices: perforated or not perforated.
Okay. What about that? Who would say that you classify only into perforated? I'm seeing nods of the head for the virtual audience. You're getting a lot of head nods. Okay.
I think thank you both. I think from a research point of view, man, that makes it easy. Yes, no, perforated, not perforated. But you read op notes from our fellow surgeons, and they're calling it suppurative, and they're calling it gangrenous. So from a research point of view, let's make it black and white, but I'm not sure that's the world we live in.
So I would agree that that's the way it has been historically, but that I hope that moving forward, we can convert more and more people to either perforated or non-perforated, because I think that's the way to treat the algorithm. You treat perforated different than non-perforated, and there's no real difference or very little difference between gangrenous and suppurative. So it's either perforated or non-perforated.
I guess if you have true gangrene of the bowel wall and bacteria translocating across that, is that different than perforated, or is that perforated, or is that not perforated? Which category does that go into?
Well, I think we'll get to the definition.
All right, so just to show you what appendicitis is going to be like, we've been debating, we haven't even gotten to the poll results yet. All right, let's go, Meera.
All right, can you hear me?
We can't. We'll turn up the volume here, but yeah, keep going, Tolu.
Okay, good. So I think Dr. Holcomb, I heard him already touch on it, and I think I heard a comment about some being research versus, being real life. Well, this has been our standard practice here for over a decade. The paper that was published in 2008, which clearly defined perforation as if you either see a hole in the appendix or there's a feculate in the abdomen. And that has been the definition that we've used for management of appendicitis. So we have only two classes. It's either it's perforated or it's not. So that picture, it depends on whether you have a hole in the appendix or if there's a feculate in the abdomen. And that is how the management in real life also goes. It follows that pathway, whether perfed or not.
Point and Dr. Wilkins' point, right? You saw differences in rates of abscess based on that definition. So when you classified people based on hole in the appendix or a feculith, it impacted your rates of abscess in a way that made logical sense, right? It reduced the rates of abscess amongst the non-perforated patients, and it increased the rates of abscess around the perforated patients. So it aligned with what you would expect in clinical care.
Exactly, because the perfed patients, in the denominator, people were throwing kids that will probably not be managed as perforation. So once you take those kids out, then the abscess rate slightly increased in the perforated patients. But you would also expect that in the non-perf patients, if we're managing perforations at non-perf, the abscess rate should be high, but it wasn't a significant difference. So that shows that the clinical management still aligns well with the definition.
So Mark, okay, this is the problem so you might be right. There might be bacterial translocation, but if it doesn't matter clinically, who cares? Because if it's not leading to a higher abscess rate, it doesn't matter.
I agree, but again, I think in the study you were talking about it didn't reach statistical significance. Have we truly studied that question? And do we have the N to study that question? So I'll ask the big data people sitting up at the head of the room.
Data man?
Yeah, so there was a group in Canada that did that exact thing. They took focal necrosis and they just brought them in-house and saw how they did. They ended up behaving like non-perf dabbies. They had a mean length of stay of 1 day, and the abscess rate was really small. So they brought them in and committed them to antibiotics. It's a pretty rare patient that is so on the fence that you just have a hard time treating them as non-perforated appendicitis. But this, to Mac's point, has become binary for us in the real clinical world because we send them home. We send them home if they're not perforated. And so it's now just a commitment. Are you going to keep them in-house for IV antibiotics, or are you going to send them home? And the patient with focal necrosis will typically fall into the group that would get sent home.
At the very end, I'm going to ask you to just fly through, okay, what do we do now? So what should we be doing now? Okay, let's keep going.
Yeah, there's lots of other, ooh, I'm loud, sorry. There's lots of other things to talk about. Oop. Okay, all right, Tolu, do you want to move us forward?
Yeah, can you see?
Yes, so that's thinking about sort of clinical algorithm. So Tolu, do you want to talk about that paper, the diagnosis and the protocol paper, and then we'll talk about dosing, which we've already kind of touched on.
Right, so in our institution, we will start with a clinical algorithm, which is based on physical exams, and then some people use the PAS score. We don't use it as often. We did use it for a while, and based on the algorithm, the goal is really to reduce the use of CT scan, which we've successfully used there, and we can track our data also in NISQUID to show that we don't use as much CT scan as we used to. And the goal of the whole algorithm is to really reduce exposure to CT, and many institutions do rely on ultrasound now. So I'm sure we're not that different in that regard. And we also use the antibiotics, which we've kind of touched on already. So I don't want to belabor that matter, whether you use Zosyn preoperatively, but the convenience with the ceftriaxone flagell is just a one-time dosing daily, and then you move on to surgery.
Perfect. So I think, yeah, we're going to skip the bottom part because we've obviously had lots of conversation about dosing of antibiotics this morning already and looked at that study. So then we talked about same-day discharge. So, thinking about how we can move patients with non-perforated appendicitis through their pathway and kind of out of the hospital in a timely fashion, and can we do that safely? So that study, Tolu, go ahead.
Yeah, so we did this. The initial study with our same-day discharge was way back in 2013-14. At that time, we had a 28% successful discharge. And we learned from that, and we continued to work on that till this recent study that we published, which showed that we successfully discharged 87% of the patient. And this has become the norm for us now, in addition to doing away with opioids for the patients. So all our patients are sent them on just Tylenol and ibuprofen, and it's very unusual for them to have to come back or have a very high readmission rate. And we're actually completing a study which we followed up with surveys, to see that patients are truly happy with same-day discharge, and the consensus so far that 90% of patients are happy with it. The few patients that have pain control, those are areas we can work on. So same-day discharge, definitely possible, and I think that's where the trend is going.
So I'm curious, for folks in the room, how many people are able to get appies, non-perforated appendicitis patients, out the door the same day, routinely?
Just for the viewing audience, I think it's almost the entire room, at least the majority of the room.
So Tolu and I were talking about this in preparation for today, and talking about kind of the way that the system things that exist at Kansas City that make it easy for them to do that. So step-down unit, right? This sort of, preparation, and the idea that you can kind of create systems that allow patients to expect to go home, and how you may move that forward. in your system, which I think is different in every hospital. Bindi.
So that patient, that picture that you showed with that clearly gangrenous appendix, that patient would fall into this, no antibiotics post-op? Correct. Yeah, that's very different from what we do at TCH. The same day discharge patients are only the simple appendicitis without gangrene, so that's interesting.
Was that they had who looked like they had focal gangrene and they were still all able to go home?
Okay, so I want to make sure we get full clarity on that. Shawn, for the record, that nasty looking appendix that doesn't have a hole or stool, you will send home from the recovery room.
If that's the decision. So in those, we would typically go to the back table and take a pair of pickups and run the whole surface. And if your pickups don't fall in anywhere, and there's clearly not a hole anywhere, but there's yellow and dark spots like you saw there, it's a commitment. So
It's a commitment.
You're jumping out of the plane, and you're just going to assume that the parachute works at that point. If you can't find a hole, then they're going to go home.
All right, here's my second question. If you're not sure and you admit them, is one day enough to know the answer?
So we'll get to that here shortly when Tolu talks about our algorithm, because now they can get better on their own accord. So they go clears, regular diet, at that point check a white count and send them home. So if they're going to behave like a non-perfed appy, if you were going to be not bold enough to send that patient home, like Bindi's talking about, you bring them in, and if they're going to behave like a non-perfed appy, they're going to prove that to you. And by tomorrow, they're going to be eating and feeling like they want to go home.
I think the fear is abscess, not that they won't recover great. You know, it's just the 1 or 2 doses of IV antibiotics, but
So far the data seems to suggest that it
Not
goes
necessarily.
okay and you don't see an abscess rate, you know, and based on that study, the abscess rate was like 0.8%, down from 1.7 or something like that.
Right.
Tolu, do
Yeah.
you want to move on to the perforated appendicitis slide, and we can talk about some of, since we've transitioned
Yeah, I think I
ourselves
had
into
some other
perforated
questions, but this will probably answer some of those questions. So we already talked about hole in the appendix. We already defined that. So now it's going to, what do we do in this algorithm when you're managing perfed appy?
I think
So
the
we
first
already-
question is the suction versus irrigation question, which we had even amongst ourselves, a lively debate around this. So do you want to share that paper, and then we'll talk about existing other evidence that's out there?
Right. So this paper is probably well known, and that was back in 2012, which compared suction to irrigation, suction only to irrigation, and the minimum amount of irrigation in this study was 500 cc's, but the average that was used was about 850 cc's. It showed no difference. So the benefit of suction, if I can call it that, is there's no added time to irrigating and also resource use. That being said, this is a randomized study, but there's another study that was a retrospective study that looked at more aliquots in 50 cc's, and they went as high as 2 to 3 liters. Retrospective study for sure. There are other things that were added to that study, which means you peel off all the fibrinous exudate, suction around the bowel, things like that you do, which can add time. But the bottom line is this study did not say one was better than the other, except there is no benefit to adding more time. Though some will still, based on the other study, say, well, irrigating might also help based on that study. But we can say probably we needed another study that was more like a randomized trial if we want to really put that to rest. But in our practice, we don't suction, we don't irrigate, we just suction. And I don't think we've seen a major difference in abscess rate.
Who irrigates
Me.
for perforated appendicitis? It's close to half, not quite half, maybe a little bit less. Makes you feel better. Treat the surgeon, not the patient.
I do it because of the study that showed that heavy volume irrigation actually has...
Right, but remember that study was not a randomized study, right? So there's some confounding by indication in the patient that you choose to do high volume, low aliquot.
Oh, it's the number...
That study was 3 to 12 liters in 50 cc aliquots.
And the number was
Yes.
substantially different.
Correct.
Very low abscess rate. When you
So
do that painstaking-
the abscess rate in the patients who were irrigated was 0%
Was
in that
zero.
study, compared
Zero.
to 18.9% in the perforated appendicitis population. But again, retrospective study, not randomized.
No one ever says
Yeah,
that.
0% abscess. I mean, I don't know. That always raises a flag for me. 0%, no patient had an abscess. And I struggle with that a little bit, which is why I do think we probably need more data.
And it's
If that's
There wasn't a definition of perforation
Oh.
used in that study.
you guys still
correct. Yes. There was the definition of the perforation, they did not say. So they could have been lumping a lot of patients that we will treat as non-perfed into that group.
Awesome, let's keep going.
Okay, so why don't we move ahead? We talked already about single daily dosing, so we don't need to do that again. And then discharge. So this, I'm the interloper. I'm the Cincinnati interloper into this Kansas City party, but luckily we do the same thing. So it makes it easy. Tolu, do you want to talk about the discharge protocol that you guys use?
Yeah, so we very much, it's very patient driven. And I think I had a question about what if you're not sure and you admit a patient the next day. The patient will declare himself or herself. If the patient is already on clears, wants to eat, it doesn't matter if it's day 1, day 2. If the patient is afebrile, good pain control, is tolerating a diet, the patient can go home. And we've seen that most of our perf therapies will leave on day 3 or day 4. And like the patient you were talking about, if you're not sure, they'll leave the next day because they'll look that good that you know that, okay, this patient is ready
It's a clinical decision, right? And these are not patients that are getting PICs and multiple days of IV antibiotics and multiple sets of labs. All of those things. We make a clinical decision based on how the patient's doing, and then get labs at that time to decide about discharge home with antibiotics versus discharge home without antibiotics.
The problem with this,
correct. The CBC it's patients ready to go home, then you get a CBC to check if they need antibiotics. That's the only reason for the CBC. We don't do routine labs.
Ponsky.
all right, 2 things the problem I have with this, and I want to know if you have the data, is I totally get everything you said, that usually by day 3 or 4, we know infections take a while to start developing. Day 1, they're not going to have an infection yet. It's too soon. So do you really trust less than 24 hours after surgery that they've declared themselves as good to go? And do we have your data to go back and see for the day 1ers the same success rate as the day 4 or 5ers?
So if I heard that correctly, it's talking about patients that leave on day 1.
Yes.
In my opinion, probably not truly perfect. Like I said, it's the ones you're not sure of. Most of the perf therapies will probably leave on day 3 or 4, not day 1. But if the patient is clinically okay, I think that should be a clinical decision and not what we think or how we think the patient will behave. So if the patient looks good on day 1, they should go home.
What I would love to see from you guys, for me to be convinced, is to look at that data. And go ahead, Shawn.
So I don't think we should focus on the extreme outlier, because that's what we're talking about here, is that patient who's just ACEs on day 1.
Okay.
The more likely scenario, the fastest we typically see, is somebody transitions between clears to solids on day 1, and then we make sure by day 2 they haven't thrown everything up the next morning.
Got it.
And it's usually day 2 breakfast is about the fastest you typically see that we end up getting the white count. But what's interesting is that when we did all these previous trials, we saw a 20% abscess rate, and that was sort of fixed across whether we used 2 different types of antibiotics or irrigation or whatever. And our abscess rate has finally dropped to about 10% since we stopped treating them like they're sick. In those other studies, they got PCAs, they got Foleys, we treated them like sick patients. And once we got rid of all of those adjuncts and just let them get better at their own accord, that's when we saw the abscess rate drop to 10%.
Can I make a comment, Todd?
Yes.
So in Cincinnati, we took a different research approach to this using QI techniques and followed. We have a nurse practitioner who is amazing. She tracks every one of our perforated appendicitis kids, and she's been doing it for years. And we tracked their abscess rate. We had a protocol that's exactly the same protocol, and then looked at abscess formation or readmission for abscess as a balancing measure. And by implementing exactly that protocol of going home when you meet those criteria, there was no change in the readmission rate for abscess.
So I just want to clarify. So if you check a white count and it's high, you still send them home, but you just send them home on oral antibiotics. 4 days of augmentin.
Okay, since that was, fun and a little bit controversial, we're going to move on to everybody's. Oh, sorry, Steve, yeah.
My question for the panel and experts here is, how do you treat a patient who is eating, afebrile, looks great, but having significant diarrhea? Do you consider that as part of being normal and just for discharge?
In our clinical practice, patients who have significant diarrhea, we don't send home at that point, because we're looking for some improvement. They don't have to be perfect, but they have to be heading in the right direction. in part because we think of that as reflective of risk of infection or brewing abscess, and also risk of dehydration. If they go home and they're having a liter of stool output a day, how do they keep up? I don't know what the Kansas City team does, but I'm guessing similar.
It's very similar.
Yeah.
It's very similar. Once they're having diarrhea, you start worrying that they're probably brewing an abscess down in the pelvis. So we can't send them home. They don't go home with diarrhea.
So maybe it should be eating, afebrile, and no diarrhea. Like, could that, yeah. Okay. Oh, so Rick Pearl just said, instead of saying eating, just say GI tract is functioning normally. I like that. Okay.
Okay, we're going to move on to everybody's favorite topic, which is non-operative management of appendicitis, which is, I'm sure, going to have some opinions about it. So our next question. So this is an 8-year-old male that presents with 24 hours of abdominal pain, a white count of 12, an ultrasound that demonstrates appendicitis with an appendiceal diameter of 0.9, and a small fecalith, and no abscess or phlegmon. And the poll question is, which one of these findings makes the patient ineligible for non-operative management? And some people in this room would say all, because they don't think that there should be any patients that have non-operative management, but just humor us for a second till we get there. All right, thoughts? Anyone think about if you're in the camp of willing to sometimes treat people with non-operative management, which of these makes a difference? Yes, Steve.
We treat a lot of patients non-operatively. We've even switched to outpatient non-operative management, where they go home within 4 to 6 hours from the ER. The presence of the appendicolith is the one that really throws us off. However, we still have families coming in asking to be treated non-operatively with appendicolith. We do treat those hesitantly, but some of them will do well. We just make sure we counsel them that they will have an increased risk of recurrence in the future.
Perfect.
We have a question from the chat asking, what is the role of CRP for discharge decision, or if you rely only on a white blood cell count?
Oh, for perforated appendicitis, we're going backwards. So yes, for perforated appendicitis, we don't use CRP. We expect that patients had an operation, they're likely to have an elevated CRP, so we don't use CRP in our decision making.
Perfect. And then the results from the poll are presence of the fecalith, 68%.
Perfect. All right, let's talk about those couple of studies. So I think 2 studies really that people should know about in the thinking about non-operative management. One is the adult side, which was the CODA trial, which was a pragmatic randomized control trial that was done on the adult side. And then there was a trial done in the Midwest Pediatric Surgical Consortium looking at this, which was a patient and family choice study. This is what you're seeing up there is the Cincinnati Children's pathway that we use, and that's based on the MWPSC study. So we use the criteria that were used in that study. And fecalith is excluded, so that answer is correct. And fecalith is excluded in part because it wasn't included in the MWPSC study, and it wasn't included in the MWPSC study in part because those patients in the adult trial and the CODA study had a much higher rate of complications and a much higher rate of going to appendectomy in the first year. So I think the big things that we see in these patients to be eligible for non-operative management: symptoms less than 48 hours, imaging confirmation with an appendiceal diameter less than 1.1 centimeters, no abscess, phlegmon, or fecalith, and then white count somewhere between 5 and 18. So the kids who have a white count of 25,000 we're less likely to think of as non-perforated appendicitis that might improve with just antibiotics. And in that MWPSC study, just so I get the data right, the patients who had non-operative management had fewer disability days, 6.6 compared to 10.9, and the success rate at a year was 67%. Now, I will say, in our practice, I would say, I don't know, a good chunk of my partners do not believe in non-operative management. And so there's a lot of variability in whether people feel like it's what we should be offering and what they would offer to their own kids.
Success rate is 67%.
At 1 year.
And the failure rate is 37%.
Correct.
So what procedure do we do?
Can you, Vindy, will you give him the microphone?
It fails 30-something% of the time. We say, oh, that's pretty good, right? I mean, yeah. I mean, think about that. I mean, we've taken an operation that we do really quickly, very well. We discharge people home in a day, and we have an incredibly low complication rate, and we've traded it in to following the kids for a year. They bounce back to the ER. The parents are worried. Every time he has a bit of belly pain, they come running to the doctor. And oh, by the way, after a year, 33% of them still get their appendix out. Not such a good deal, I wouldn't say.
So one of the things that was interesting about the CODA trial was when they actually started the adult trial and they tried to figure out how they wanted to set their primary outcomes, they actually set it at quality of life because that was what patients and families said they cared most about. And when they looked at quality of life as an outcome, they found that doing antibiotics only was not inferior to appendicitis for quality of life, which was the outcome that patients and families cared most about.
Okay. So,
when we designed the multi-center trial, we had this exact same debate, and we were designing it as a non-inferiority trial. And this is a study that hasn't come out yet. The data will be mature in 4 months. We finished enrolling last fall, and the 1-year follow-up will be complete this November. And so we'll be talking about this next year. But in that, we had this debate about at what point do you just say that's too high? And most of the surgeons landed on around 20%. So that's where we set the mark for the non-inferiority margin. And what we're seeing at the interim analysis is the exact same results. It's around 31, 32% 1-year fail rate. And so we'll see what the final data is, but we'll also be able to clearly define the effect size of having that fecalith there, because this was also a pragmatic trial, so those patients were included. And and I think that that's what we're going to be left with, and that's kind of why I was mixed on even bothering with a trial, was because you just need to know that number, because it's what that number means to mom that's the difference. Is you got a 30% chance of coming back and doing this again. There are folks that you meet in the ED who are like, what I've just dealt with for the past 24 hours, if it's 0.3%, I'm not doing that. Take out the appendix. And then there are people who think that 30% sounds reasonable if they can avoid an operation.
I might be playing devil's advocate here because I do surgical treatment. No, I don't do non-operative treatment, but not all failures are the same. 30% failure means that they will come back, they'll have an operation. When they look at the histology, not even all of them had appendicitis. So for some people, for some parents, their quality of life is better. They won't have an overnight operation, and even they've measured how many days they're absent from school, and with non-operative management, there's a non-significant, like 3 days extra going to school. So not all failures are the same. It's not like a catastrophic failure.
So in the original, I guess it was a pilot study out of Stockholm of 50 patients. At 5 years, I think the follow-up was 5 years, I think there were 40% of patients who had an appendectomy for a variety of reasons. And not all of them, I mean, some had recurrent abdominal pain, and some actually had true appendicitis. But anyway, 40% of the 50 patients, I believe, underwent an operation within 5 years and had an appendectomy performed.
All great points, and I agree with all of them. A lot of our patients seem to have an interval appendectomy, and that's why we've actually gone to the outpatient management, because we think you can outpatient treat them, they go home, we see them in follow-up and have a true discussion, and a significant portion of them will say, let's just have an interval appendectomy. Again, you schedule it, it's elective, and that will probably be a better quality of life than admitting, and sometimes in our hospitals, getting these patients on for an operation takes a while. So we'll be interested to see how that matures.
For those who couldn't hear. All right, I think that those are what we wanted to talk about. Does anybody have other comments or
any other final comments? Jose?
Sorry to go back to the definitions. I know we talked about how useful it is to talk about binary, black or white, perforated and non-perforated, but there's actually another study by Shawn St. Individual findings after kind of educating their whole or standardizing their whole findings, and they analyze individual findings to intra-abdominal abscesses and increased resource utilization, and they agree with perforated appendicitis, but they also included fecalith and diffuse purulent exudate outside the right lower quadrant or pelvis and abscess. So I think it's adding a few shades of gray to that black and white definition.
But I wonder a little bit if you saw diffuse purulent exudate, if you did what Dr. St. Peter's talking about and you ran a pickup through the inside of the appendix, would you find a hole?
Those were individual findings.
Yeah, so that ends up being functionally a prognostic study. Now, obviously, separating those categories is extremely difficult to do, as Mac was alluding to, looking at the outcomes. Even if you do it prospectively, extremely difficult to separate out. Is there a little bit of pus in the right lower quadrant? I mean, in the right upper quadrant? Is there a little bit of pus in this other area of the abdomen? Really hard to separate out those categories. But when I look at that, that's purely prognostic, in that you have a patient and you say, well,
I saw a couple of small abscesses, therefore they're at a higher risk of abscess on the basis of that. I'm not going to treat them any differently, because you have those patients that have a bad abscess, you do the appy and they fly. And you have those patients that looks like it's not bad at all and they just flounder for 7 days and end up being diagnosed with an abscess. So the treatment still is dichotomous, even if you add these shades. To me, that's more prognostic, and that you could tell the family. For example, we've shown that patients who are obese have a higher risk of an abscess. So you can tell families this patient has a higher risk of an abscess. If this data ends up maturing and those shades are real, I still don't think it's going to change treatment, that therefore you get an automatic 5 days because you had abscesses. I think you still are going down the path of inpatient therapy until you're better.
Awesome. This was a great discussion. Thank you, Meera, Tolu, Shawn, and Whit. Hopefully next year we'll have a whole new look on appendicitis. All right, we're going to take a break. We've got 2 hospitals to highlight here who helped support this event. We have UCLA Mattel Children's Hospital and Cincinnati Children's Hospital, who have been great partners. We're going to come back and we're going to talk about congenital esophageal stenosis. Thanks.